retired NFL football player. Ever since this one tackle when I was playing, 4 years ago, the shoulder just never been the same. And I've had X-ray, I've had MRI, and no one says anything's wrong with it. But I can't lift it past 90 degrees, and they don't say it's frozen shoulder because yada yada yada. And I worked on him for about probably 25 minutes, and he had full range of motion back in his shoulder. Welcome to Straight to Health. My name is Dr. Gavin Hall. I'm your host on this podcast. I am a local chiropractor here in St. George, Utah. I started this podcast a few months ago and have just enjoyed sharing health and information about how to fix yourself and a couple of ways that I've found that can maybe speed up that process. All right. Today, we're going to talk about shoulders. We've talked a lot about hips, knees, ankles, and a lot of different injuries in the past. We've had a couple of great guests on, and I've appreciated their time, and I appreciate any listeners that have been following me along. I hope that this has been educational, because that's my goal, is to educate you to make you able to make a good decision on the health that you receive for your body. So today we're going to cover the shoulder. All right, we're going to talk about why it's pretty prone to injury, the style of joint it is. It's a little bit less stable than most other joints. We're going to get into why. Then we're also going to cover probably the top 10 to 15 injuries, most common injuries that I see in the shoulder, and maybe how you or I might be able to help you get through those injuries. Okay, so a little bit. I'm just going to dive right in. A little bit about the shoulder. It's considered what we call a ball and socket joint, which means kind of like in a car, you have a ball joint and it just comes into the side of the shoulder blade, okay? So it doesn't just stick on the side of the rib cage. What happens is your shoulder blade is this flat piece of bone on the side of your back, and you have this ball on your humerus bone that comes into a little socket that's on the side of your shoulder blade, all right? And those kind of just tuck together. And that's all it is. Okay, which makes it difficult, and why it's a little bit more unstable than most joints, is because if you were to pull away the muscles and the ligaments, it would fall off. Many other joints in the body, like the elbow, they kind of have this hinge joint where as the two bones come together, you pull the ligaments and the muscles away, and gravity can kind of keep them together, all right? But the shoulder, it just all falls apart. Okay, and the same thing happens with the hip, but if you're standing up, you pull the bones away, the hip can kind of be supported by the femur bone that comes into that ball and socket joint. I didn't really cover that in the hip video or in the hip episode, but it's kind of the only two ball and socket joints in the body are the shoulder and the hip. So it's kind of the difference between the shoulder and the hip is that the hip has a little more stability because you put weight on it, which creates a little bit more stability through gravity, where the shoulder, you only have load through it when you put load on it during a push-up or using your arms at all. Okay. Oh, also, I forgot to mention, you're probably going to see me referencing some notes. There are a lot of different components to the shoulder and complex problems in the shoulder. So I wrote myself an outline to try and keep my thoughts a little bit more organized, because you can seriously get down some tangents in the shoulder. And I wanted to make sure that I wasn't chasing any of those rabbit holes. So I've organized my thoughts just a little bit, because I've really wanted to make just an awesome video on the shoulder. But part of this I wanted to mention here as well. Most injuries, in my experience, in the shoulder are because of two things, either the labrum or the rotator cuff. Okay, we're going to get into some of those, but I want to first finish a little bit more about the anatomy of the shoulder. We talked about it being a ball and socket joint. You have your humerus bone that goes into your shoulder blade. Your shoulder blade bone is formally called the scapula. So if you've ever heard that, the scapula, okay? And then you have your clavicle or your collarbone that comes from the front and attaches out to the side as well. All right, so those are the three bones that are considered part of the shoulder joint complex, okay? Now, there are 18 muscles in the shoulder that impact shoulder motion. And when we say shoulder motion, it is your humerus and your shoulder blade, but also your scapula, your shoulder blade, and your rib cage. Okay, so some of these muscles, like the rhomboid muscle, doesn't directly come over what we would call the shoulder, but it greatly impacts the shoulder and how the shoulder moves. Because here's a fun fact, I'm already down a rabbit hole, but if you lift your arm up to about 90 degrees, your shoulder, this collarbone and your shoulder blade will stop the motion in that, what we call abduction of the shoulder. Okay, you can't go higher unless your shoulder blade pulls forward to allow you to go higher. Okay, so that's kind of the importance of the shoulder blade. It really impacts how the shoulder is able to move and that range of motion that you'll get. Okay, now back to the shoulder muscles. There are 18 muscles in the shoulder. I'm going to read them off, but you can infer that there are some others. There's like a silly one called the omohyoid that technically crosses the shoulder joint, but in my opinion doesn't impact the shoulder as much as other muscles do, okay? 18 muscles. Of these 18 muscles in AMIT and the NPI model, those 18 muscles are broken into different divisions based on what specifically the fibers of the muscle do, okay? So by name, there are 18, but there are actually 45 divisions that we treat as part of the AMIT and NPI process, okay? So the first and most common four are the rotator cuff muscles. You have supraspinatus, infraspinatus, teres minor, and the subscapularis. They name these all based on their location. You have on your shoulder blade, if we were to show you a picture of your shoulder blade, there's a little, what they call the spine of the scapula. If you poke on your shoulder blade, it's the hard thing that comes right down the back of your shoulder blade. Okay, that's called the spine of the scapula. So if you think of supraspinatus, supra being above, that muscle's above the spine of the scapula. And then you have infraspinatus, the muscle being below the spine of the scapula. You have subscapularis, sub being below. You have a muscle below the shoulder blade. So it's on the underside of your shoulder blade. Subscapularis, okay? And then you have teres minor, a little bit of an outlier. But the idea, they call these rotator cuff muscles because they have to do a lot with the stability of the joint rather than the strength of the joint, okay? The commonality between all three is they call these the rotator cuff also because they sit on something called the greater tuberosity of the humerus. They all connect to the same 1.5 inch, radius area on this particular part of the humerus called, I just said it, but now it escapes me. Anyhow, so they all connect to the same part of the bone, but that's why they call them the rotator cuff muscles. And a small way to remember what those muscles are, if you want a fun fact for the day, is we call them the sits muscle, S-I-T-S, the sits muscle of the rotator cuff, because they sit on the greater tuberosity. There it is, greater tuberosity, it came back to me, because they sit on the greater tuberosity of the humerus. All right, so S being supraspinatus, I being infraspinatus, T, teres minor, and the S at the end sits subscapularis, okay? So just a way that you can remember those, there are 10 divisions of those 4 muscles. So if you were to come and say, hey, I've got a rotator cuff problem, I'd say, hey, we need to fix 10 divisions of your 4 muscles in your rotator cuff. All right. We're going to get specifically into rotator cuff injuries in a second, but the rest or the remaining muscles in the shoulder, after those 4, there are 14 other ones. As I mentioned, there are 18. We have your subclavius, which is under subclavius being clavicle. All right. We have your pec major. Most people know the pecs because they're big and people like to show them off. You have your pec minor. That's less obvious to what we call hypertrophy. Hypertrophy is to enlarge the muscle. So it's less common to see and go, oh my gosh, you've got a great pec minor, because it's underneath the pec major. You have a coracobrachialis that comes from the top of your shoulder blade here to the bottom of your humerus. You've got a trapezius. Everyone knows your traps. We call them the traps. That's probably one of the biggest muscles in the body because it connects from the base of your skull and shoots all the way down to like below your mid-back. And then that whole muscle shoots out to the shoulder blade. And the trap actually does many different motions. And so that one's divided into 4 divisions by itself because of its different function in the shoulder blade and shoulder joint as a whole, okay? Then you have your serratus anterior. The serratus anterior is like a little, they call it serratus because of a knife, because it looks like a serratus end of a knife when it connects to your rib cage here, and then it shoots back to your shoulder blade, and it helps you pull. I mentioned that pull the shoulder blade forward. It's one of the main muscles that will do that motion in the shoulder blade, okay? let's talk about, the lats. Everyone knows about the lats. Latissimus dorsi. All right, the lats have the main job of pulling your elbow to your side, like in rows and things like that. That's the most common one. People are like, oh, I'm going to work my lats. I'm going to do rows today. The lats are very important. A lot of these are strength, what I consider strength bringers. As the rotator cuff I mentioned was stabilizers, I like to call these the strength bringers because they don't do great at rotating and doing small movements, but they do great at pushing, pulling, doing the main effort, the force, the load. They handle a lot of that load in the shoulder. All right. So that's your lats. You have your levator scapula, levator being to lift the scapula. All right. So all it does is it lifts the scapula. It's your shrug muscle. All right. It's great. The traps help with that because of their connection points, as I mentioned earlier. But the levator scap has one job, and it's to lift the shoulder blade. All right. We talk about the rhomboid major. A lot of people will hear rhomboids. And all that does is it pulls your shoulder blades together. Okay, you have rhomboid major and rhomboid minor. They're two separate muscles. You have your teres major. Teres major, we like to call it the lat's little helper because it helps the lat with all its things, but it also helps with a little bit of external rotation when we talk about the function of the shoulder. All right. And then we have the deltoid. Everyone loves the deltoids. All the deltoids do is it abducts the arm or brings your elbow out or away from your body. All right. So if you're trying to do lateral raises and things like that, you're using a lot of that deltoid. And then a couple of ones that most often aren't associated with the shoulder joint directly, but they do cross the joint. And anytime that a muscle crosses the joint, it will impact the function of the joint. So your bicep muscle, most people will say, oh, I just do curls with my bicep, which is accurate because it connects down into your elbow. But the bicep crosses the elbow and the shoulder because it connects to the front of the shoulder blade, believe it or not, to have this muscle then go here, but it also comes here. Okay, so it flexes the shoulder while flexing the elbow at the same time. Bicep being two, bicep, there are two different halves to this bicep muscle. And so the first half will do more of that curl, the second half will do more of the shoulder flexion. But it does impact the shoulder quite greatly. That's why a lot of people get bicipital tendonitis, which we're going to talk about in a minute. But it does impact the shoulder. The last one that I want to mention as part of these 14 muscles, outside of the rotator cuff being 18 total, is the tricep. Tri being 3. There are 3 different portions to the tricep muscle. And the long head of the tricep, the other 2 heads attached just to the back of the humerus, so they do not cross the shoulder. The long head of the tricep does cross the shoulder, so it will impact extension of the shoulder when you're trying to reach for something behind you, but then you also engage a lot of other muscles when you're trying to reach for that anyway. So we're going to get into those complex movements maybe in another time, but for now I just wanted to establish that is kind of the anatomy of the shoulder. And if you came into my office and say, hey, I got this shoulder pain, I assess all of those 45 divisions of each of those 18 muscles, okay? To make sure which ones are actually part of the problem. Because we've talked about this in previous visits or in previous episodes, but I want to cover it again. If any of those muscles are not doing their job in full, then you have compensation. Compensation brings more tension and load onto other muscles of the shoulder. And then you're going to say, well, anytime that I do a bench press, my deltoid really engages and I have pain. Okay, well, your pec's probably not working because the primary load should be on the muscle that you're trying to hypertrophy or use, okay? So stability depends greatly upon the muscles and the soft tissues. That's why it's very important for that sake of the ball and socket joint that you get as many of these muscles working as possible because the more muscles that you don't have working, the more instability you get. Instability then can impact the number of dislocations you ever have. It can impact the stability and pressure on the labrum. It can then increase or decrease wear and tear. If you have fewer muscles working, it can impact the wear and tear on the joint. You then get arthritis, which we're going to talk about later as well. That's kind of the idea of this, is that if you don't have stability of that shoulder blade, or that shoulder blade and shoulder, or the humerus as well, that you're going to get some weird function and pain and frozen shoulder and other things that we're going to talk about because of the muscles not stabilizing. So injuries in the shoulder also will overlap with other pains. And I say that because I think I mentioned this in the hip video as well, the hip pod episode. But when you have shoulder muscles that are not doing their job, you are going to have neck muscles and back muscles and elbow muscles that will try to compensate from above down or below up to try and compensate for damaged muscles in the shoulder. Okay, so if you go, well, I have this neck pain and I feel like it shoots down to the shoulder, it's likely because you have neck muscles that are trying to do the job of shoulder muscles. Or if you say, well, every time that I try and engage in a lateral raise or something similar, then my back, spasms, or my rib hurts, or something in my back gets out. You know what I mean? If you have any pains in other places than the area that you're trying to work out, then you can assume that you've already got a compensation from the muscles above or below that are impacting and adapting to the trauma that you've previously had to the shoulder. All right. We're going to get right into some shoulder injuries now. So the first I want to talk about it is probably the most common injury that I see for the sake of shoulder pains. They call it impingement syndrome, also known as rotator cuff tendonitis. All right. I think I've covered this in previous podcast episodes, but a tendonitis happens, tendinitis, itis being inflammation or pain. You have inflammation or pain in a tendon, tendonitis, okay? Tendinosis, very similar. So you have pain in a tendon of your rotator cuff. That almost exclusively, in my experience, every time I see someone with, oh my gosh, I've got impingement syndrome or tendonitis, it's because you have many muscles. We said 45 in the shoulder, right? 45 divisions. If you have half of those not working or more, then something's got to take the load of the muscles not working. Then you get pain because it's trying to pull super hard, and it puts extra tension on that tendon. Tendon becomes inflamed. You now have impingement syndrome or rotator cuff tendonitis. Okay? Simple way of fixing that, we activate other muscles. The load is distributed, and there's no more tension, or there's no longer too much tension on that bad tendon. Okay? Typically, you feel this when you're lifting your arm overhead. If you do like a lateral raise and you're, oh my gosh, I have pain like on the top of my shoulder, or I get pain when I sleep on my shoulder at night, or things like that. Those are almost every time impingement syndrome. We can clean that up. Typically, I see that in 3 visits or less. But every problem is different. I hope I've established that in previous episodes, that every injury is different, because if you actually have the pain in your shoulder and the problems in your neck, we got to fix your neck. That's a different conversation as well. I've probably addressed that in previous episodes. All right. Let's see the next one. Let me make sure I've covered. Oh, if you don't have anyone local that does AMIT or NPI, then I would say your recovery for the sake of an impingement syndrome, you're looking at a couple of weeks to months. You need to rest it. You need to do some PT. But overall, they'll just say it'll go away on its own. The reason why it goes away on its own, in my opinion, and the theory of AMIT/NPI, is because you just gave it enough time for the body to effectively adapt. Does that make sense? The pain actually, the problem isn't actually gone. Your pain went away because the body effectively adapted or compensated the load that you're putting on it. Because you likely said, well, I'm just not going to do lateral raise anymore. Pain went away. That's great. You didn't load the joint the same. The body didn't have to adapt. You just stopped loading it, and so the pain went away. All right, that's the most common. People will just tell me, I just stopped using my shoulder because it kept hurting. I'm saying, well, there is a solution. We just get the muscles working. Okay. All right. Number 2, rotator cuff tear. There are 2 types of tears typically when you talk about the rotator cuff. All 4 muscles can be torn. All right. When you talk about these sits, like I mentioned earlier, all 4 can be torn. But there are 2 types of tears that I want to make you aware of. There's a partial tear of a tendon and a full tear of a tendon. If you think of any muscle like a rope, if you partially tear that tendon, it's kind of like the rope becoming frayed. All right. And that fray, if not taken care of, can snap the rope. Okay. So when we have a partial tear, fantastic. If you have a full tear, the rope snapped. All right, the muscle has broken. I cannot fix that. You will likely need surgery because they will grab the 2 ends, put it back together. You can choose, of course, not to get surgery. All right, the only way to really fix a full tear is surgical. Otherwise, you can let it ride, and your body, because the 2 ends of the rope will have snapped, the body typically will just keep those at each end depending on where it broke. All right, the body will just keep those there, and you just can't use the muscle. Your body will create adaptations, as I mentioned. If a muscle doesn't work, it will create adaptations to try and make that movement happen. But you'll probably go, oh, ever since this injury, I just haven't been doing this anymore because it hurts to lift my hand overhead or something like that. I'd say the most common tendon that I hear is torn, a full tear, is your supraspinatus, because the supraspinatus, if you damage the deltoid, supraspinatus is tiny compared to the deltoid. And if the supraspinatus has to take tons of that load, then that tension over time snaps. All right, so that's a full tear. All right, I can't do anything with a full tear. I can increase the amount of compensation for the torn muscle because we'll activate the deltoid, we'll activate the ones around the problem. But in the end, the best way to correct a full tear is just surgically reattach it, let it heal, then we'll activate it, we'll get it moving again, working again, and then you should be right as rain. I get a lot of successful cases with people who will surgically reattach those two ends, let it heal, and then we do some muscle activation. It right as rain. All right. Let me just recover here from, this feels like trouble lifting the arm. Yeah, because the two ends of the muscle have snapped, you're going to go, I just can't get it there. All right. There's something called the drop arm test that for the supraspinatus muscle specifically, because it's torn so commonly, that if you have someone or you bring your arm up in front of you and you can't hold it up, it's because the muscle's just not connected. And so there's no connection and it just collapses because there's no two ends of that muscle meeting, okay? So that's the best way to know if it's a full tear. You're gonna be, it's very clear. If it's a partial tear though, we can get some great success with that. Because if we activate the muscles around it, just like I would do in a full tear situation, we activate the muscles around it so there's less load on the injured muscle, then the injured muscle has a lot more ability to heal. So I would say, hey, let's activate a bunch of muscles, and then we rest. That way those frayed fibers can start to heal together again, and then you're right as rain. So there's a combo of things here. You need to rest and let it heal. But then I'd also say if you have heat or red light, or there are a lot of different modalities, ultrasound, that will stimulate the healing process. Okay, you can try a shot as well. What are they called? Not a cortisone. I'm not a big fan of steroids. I mentioned in probably previous episodes. It's the stem cell. You can try stem cell. You can try, there's another one as well that will help. That'll help regeneration. All right, the healing process. I'm not a big fan of steroids just because they will help the inflammation. They'll take the inflammation away, but they don't necessarily help the healing process to stimulate, okay? So if you're going to do anything with a partial tear, just increase the healability of your body by increasing heat, increasing blood flow, getting some stimulation of the mitochondria in the area. There's a lot of different ways to do that with red light and with a sauna or a hot tub, wet, moist heat, things like that. Just get your body to heal that, and you should be right as rain. All right. The next, number 3 that I want to talk about is the rotator cuff strain. All right. This is just an achy style pain that often comes in your shoulder after a workout. All right, so that achiness is the same idea. You have overworked a muscle, or you've previously damaged your shoulder, and now every time you work it out, it just hurts all the time because you're stressing and putting load on muscles that can't handle. Okay, you've damaged a couple, and so there are we'll say 20 divisions of the muscles that are doing the job of all 45. Okay, and so those strain comes from those 20 muscles working really hard to try and compensate for the load that you want to put on all 45. All right, that one's same. You're going to rest it. We're going to poke some muscles. We're going to activate some muscles, and you're going to get it better. Now, if you remember back to episode, I think it was 2 or 3, we covered what AMIT is and how you injure a muscle. All right, so you injure a muscle most commonly because of trauma. If someone gives you a dead arm, if you ever get whopped on the arm, that feeling of that arm going, oh man, that hurts, I need a minute before I can use it again. You've damaged the muscle, all right, it's shut down, period. So that's the most common one is trauma. You then have overstretch. Okay, overstretch is going to be things like a whiplash. In this case, for the shoulder that I want to cover, a dislocation. You have overstretched the muscles to the point of dislocation, and it will shut down a large number of muscles. Typically, after the first dislocation, you will notice that every subsequent dislocation happens easier, kind of like an ankle sprain. You roll the ankle once, the next ankle roll is right around the corner. All right. The more times you dislocate the shoulder, the more muscles you shut off. the more muscles you shut off. We already talked about it being the most insecure joint in the body. And the more muscles you have off, the more insecure it's going to be, and you dislocate it more and more and more. And I've had some people come in my office, they say, I can intentionally dislocate it just if I do this, and it'll pop out of socket. All right. I've helped a lot of people with dislocated shoulders. We get some muscles back working again. It brings stability back to the joint, and they find incredible relief in the stability that comes. Anytime, as a lacrosse player specifically that comes to mind that I treated probably a couple months ago now, but he had dislocations all the time. Anytime that he would check someone, he would dislocate his shoulder because the force that came through the back of his shoulder would just dislocate his shoulder. But he would know because it happened so often, he'd just pull on his arm, it would relocate it, and he'd keep playing. And so we treated him, and he hasn't had problems at all. I think he came in 4 times, and he thought, oh my gosh, my shoulder feels brand new again. Like I haven't dislocated it the last 3 games. So that was kind of a fun one that we've had recently for the sake of shoulder dislocation. Any fall can dislocate the shoulder. I'm sure you're aware that if you fall and you try and brace yourself, if any jarring motion or any jarring force to that elbow could pop that out. It could pop it back. It could pop it forward if you're pulled super hard. Just depends on if you're tackled from behind in football, for example, and your shoulder got stuck in the way of tackling someone else. It can pull it forward. You then get a dislocated shoulder. All right. There is another injury that I'm going to cover right now, actually. It's called a bank heart lesion. The bank heart lesion is a tear in the labrum that typically happens after a dislocation. So if you think of the labrum like in the hip video, the hip has a labrum as well. The labrum is kind of like a meniscus. It keeps the bones from rubbing on each other. You have 2 bones, and God wanted to say, hey, if you put 2 bones together, that's never a great thing. So we're going to put a pad in there and cushion the 2 sides, okay? That way the bones don't rub at each other. That's called the labrum. It's a little squishy thing. And what happens is as you dislocate that shoulder, whether it's back or forward, that the pressure as it's coming out of socket, you have a lot of pressure on the front or the back side of that joint, okay? And as that pressure increases on the labrum, it can pop, so to speak, or tear the labrum. All right, and so that's what they consider a bank heart lesion. It's a tear in the labrum at the bottom or front of the labrum, usually after a dislocation because of the amount of force that comes through that dislocation. All right, but as a whole, if you don't do any muscle activation, you've got years of rehab ahead of you. You've got a lot of muscle strengthening needs to happen because you need to try and increase the compensation in the shoulder. So do yourself a favor and just stop by someone who knows AMIT or NPI, and they can make your world a lot easier to recover from, especially if you're an athlete who's got a bad shoulder. I actually just treated in June. There was a gentleman who I went to a local football camp to donate some time and just work on some of the athletes there. And it was a retired NFL football player who had come to support the kids as a coach and trainer at this football camp. And I was just showing up, to say, hey, I'm here to help people. Let me know, if anyone has any problems, bad ankles, if you're running, whatever it is. And this coach actually came up and he says, hey, when we get a break in the training, I'd like to come and have you work on my shoulder. Because ever since this one tackle when I was playing, 4 years ago, the shoulder has never been the same. And I've had x-ray, I've had MRI, and no one says anything's wrong with it. But I can't lift it past 90 degrees. And they don't say it's frozen shoulder because yada, yada, yada. And I worked on him for about probably 25 minutes, and he had full range of motion back in his shoulder. So even old injuries can certainly be healed and fixed if we do the right set of muscles to bring stability back to the joint. Okay? I'm going to stop there. I'm going to get down rabbit holes. I'm glad I have my mind needs to straighten up here. So you can have a partial dislocation in the shoulder. You can have instability. They call it multidirectional instability of the shoulder. It's just naturally loose under multiple directions if you force it. And that's typically, as I mentioned, because of previous traumas. And the more times you injure the shoulder, the less stability it has. But we can reverse that. Okay? People will call this being the multidirectional instability. People will call it I'm being double jointed. Look at this. I can shift my bone around. It clicks and pops and shifts and makes some nasty noises. That's not a great thing. If you do that, I wouldn't recommend that you continue to, because all you're doing is you're stretching out the ligaments more, because that's just more instability. Any double jointed, actually, there's no such thing as being double jointed. You don't actually have two shoulder bones that it shifts from one joint into the next, right? All it is it's so much laxity in the joint that the joint flops around and makes noises and pops around. So if you are double jointed, that's not good to increase or move it so much that it shifts and pops, because all you're doing is you're creating more looseness in the ligaments and the joint space. Don't do it. Just come to me or find someone else who does AMIT or NPI, get the muscles working. You will probably no longer be double jointed, so you don't have the party trick. I apologize, but it'll be worth it in the long run for the stability and the pain that you're going to feel in your shoulder or your knee or your fingers or whatever it is that you have your double jointedness. All right. Okay. Slap tear. Tear. So slap tear is that labrum tear. Slap being superior. Oh dear. Superior lateral acetabular. Wow. I'm going to have to write this down and look it up because I cannot remember. It's a tear in the top part of the labrum where the biceps tendon attaches. It's a superior labral acetabular. What's the P? Darn it. Okay. Well, anyhow, the symptom of this is just a deep pain, a catching, a clicking in your shoulder, or a weakness as you're trying to come up. All right. It's common in baseball pitchers and weightlifters and things like that. If you've got that problem, we can correct that. We can correct the weakness that comes from it. Okay. The tear that happens in the labrum depends on the severity of the tear. Your labrum, depending on the size of the shoulder, size of a 50-cent piece or so. Now, if you have a centimeter tear, it might not sound big, but that's actually a pretty big tear. And the bigger the tear, the less likely it is to heal on its own. If it's a small tear, they'll typically say, oh, just let it rest, do some PT, and the tear will fix itself. With some scar tissue, it'll just come back across. But in the events that they don't, the best recommendation even that I have is if it's a big tear, go get it surgically repaired. They'll sew the two ends together, they'll make it stable, and then we can get some muscles working again. If you've said oh, I've had this shoulder pain for 6 months, okay, and I don't know what it is, and you come in and we do a couple of muscles and you're like, there's no improvement, or even if I treat the muscle and you come back for visit number 2 and the muscles shut back off again, then I know, back to that circuit breaker idea with the AMIT concept, okay, that tells me already that you have a greater trauma in the shoulder and it's tripping the breaker again and shutting the muscle back off. So if you come in for visit number 2 after the work we did in visit number 1 and everything's done, I'd say, all right, stop wasting your time here. We're going to get an MRI on the shoulder because you likely have a tear in your labrum. All right, so just to be clear with that one, I don't like wasting time. And if muscles that I've previously done are shutting off, we're going to find out why. So, but most commonly it's people who have had pain forever, like 6 months to a year, and it just won't get better. It's probably because they started with a small tear and they keep stressing and stressing and stressing the joint, and they never let scar tissue fully heal that joint, that tear. And then it's just still a tiny tear, or it could even be growing into a bigger tear if you don't get it checked out to see, what stage is it in, what type of a tear it is. There are multiple different tears as well. I covered some of those different tears in the labrum of the hip. I think it was 3 episodes ago. So if you're interested in the types of tear, there are very similar tears in the shoulder labrum as well. But those are typically best done via surgery if it's bigger than so many centimeters, okay? And I don't know the exact on that one. I would say go, if you're concerned about how bad the tear is, talk to an orthopedist. If they recommend PT, then I'd say we're going to be probably more effective in the muscle strength testing, but keep doing some exercises. I'd say YouTube some labrum exercises and just do those and then get some muscles activated. But that's me. So, yeah, we talked about that one. Bank heart lesion, I covered that a little bit. The recovery with that one is just a bunch of rehab, and because oftentimes those bank heart lesions are relatively small, and so they will and should heal themselves. But in the event that you keep using the shoulder because you love your sport and you keep using your shoulder, you might want to just get it surgically repaired so it gets done. All right. You have a general labral tear. I think I've hit the labrum pretty good. But if you feel that you have pain when you load your joint, like if you're doing a chest press and you have pain just deep inside that shoulder, you likely have some sort of a labral tear in there. So get it checked out and make sure you don't. But that's kind of the idea with that one. If you just feel it deep inside the shoulder, and that happens because if you load and put weight on the shoulder, it squishes the disc, the labrum, it squishes that between the two bones, all right? And the pinching of that or the extra pressure on the labrum is what kind of helps split that tear and put stress on that labrum a little bit. And that's why it causes that pain deep inside. Okay. That one, like I mentioned, depending on the severity, I would either say surgery or muscle activation with some YouTube PT stuff. All right, then you can get shoulder bursitis. Shoulder bursitis is just this pain on the top of your shoulder that anytime that I lift the shoulder up, I just get pain up in here. That's because underneath your deltoid, you do have what we call a bursa. A bursa keeps tendons from rubbing on bone. All right. And so if this bursa becomes inflamed, then it becomes kind of fat and inflamed. And they typically just say, just ice it. It'll go away on its own time. In my experience, yeah, sure, ice it. It'll go away because that'll decrease the inflammation. But we still need to activate the muscles that are causing the pull on the bursa incorrectly, or that might be chafing some of that tendon to cause the inflammation on the bursa. All right. So that one they recommend rest, PT, some injections, some ice. Yeah, that's pretty much it. If it feels like someone stuffed a balloon in your shoulder joint, that's kind of how they talk about that one. All right, then we have a bicipital tendonitis. We're almost done, guys. Thank you for sticking on so far. We have bicipital tendonitis. I would say this is another one of the more common ones that I fix. It's just pain on the front of your shoulder. Anytime that you pull your arm up, if you're working your bicep, you're trying to flex your shoulder, you get pain right in here at the front of the shoulder. It's likely bicipital tendonitis. That's just because the bicep tendon is doing a really good job at pulling the weight of your coracobrachialis, your deltoid, likely some of your pec. It's just compensating, which puts a lot more load on the bicep. You then get inflammation of the tendon, and it hurts. All right, we redistribute the load, we reactivate some of the other muscles, and bam-o, bicep tendonitis gone. All right, this is, pain with curls or reaching forward. Most people will do PT for this. They'll do injections to help the inflammation, but then over the next time, if they work out regularly, it's just going to come back because they can get the inflammation gone. But then you try and work out again, the pain comes back because the load is still on the biceps and not distributed effectively throughout the joint. Okay. Calcific tendonitis is kind of the calcium deposit that's in the rotator cuff tendon. It's very much less common. Typically, you just have to either surgically remove that one or the body will get rid of it on its own if it finds it genuinely a problem. I have never found that to be the reason that muscles do not activate. So in my experience, I don't like the calcific tendonitis diagnosis, if you will, but yeah, they recommend, this is like pain is so bad, people sometimes think it's a heart attack. It's because it's sudden, sharp pain that just gets you, and then it goes away, and then it gets you, and it goes away. That's just because you have this calcium deposit that's in the tendon and it's trying to contract. That's the theory behind it, but I haven't found that to be a problem most of the time. A little bit of muscle activation can fix that. All right. Then you have osteoarthritis or any arthritis in the shoulder. The solution to that one is depending on the severity of the joint, you need to replace the joint. Okay. If you go into a PT or a surgeon, they're going to often recommend that you just do a shoulder replacement. In my experience, I covered this in the knee episode, but in my experience with arthritis, if you have arthritis in any joint, I can't make the arthritis go away, but simply by making the muscles do their job to redistribute the load across the joint. If you can put the load on the muscle rather than the bone, then you don't have stress on the arthritic portions of the bone and the pain will often go away. All right, I have not yet to date had someone come in with arthritis in their shoulder that did not get significantly or completely reduced or treated by muscle integration, okay? Oftentimes you'll be recommended to do some activity modification, do some PT, do some injections just for the pain, and then eventually a replacement. Okay, the most difficult thing that I have treated to date and the next diagnosis on the docket for number 14 is the frozen shoulder, also known as adhesive capsulitis. This is tightening and thickening of the joint capsule. All right, this is severe stiffness. The most common thing that people will recognize with this diagnosis is I just stopped being able to move my shoulder. I can't move it more than 30 degrees in any direction. All right. If the shoulder stops moving, that's why they call it frozen shoulder, because you lack all the range of motion that should be there with normal motion in the joint. Okay. I activate a bunch of muscles with this one, and typically I can get it to about 90, sometimes 120 degrees of motion. So you'll get some good improvement. I have not yet to date been able to get full range of motion with muscle activation. Just full disclosure, you'll get significant improvement, pain reduction, all the good things, but I haven't been able to get one of those yet completely repaired to 180. I think there's something else in the body with that diagnosis that both I am unaware of, and that the general populace of physicians doesn't know fully why the body does do adhesive capsulitis or frozen shoulder. In theory, it's because you have so many muscles that are a problem or so much damage to the joint that the body just says, nope, we're not moving that anymore, because I know if you start messing with it, you're going to be a lot worse off. So the body kind of makes an executive decision and keeps it right by your side. That's my opinion. However, like I mentioned, we still don't know why that really comes and how it just over time, typically with this one, they'll say, oh, it can recover on its own and takes up to can take from anywhere from 1 to 3 years. And oftentimes it'll just resolve its own. It'll freeze. And then over the course of your PT and some muscle activation over the next year to 3, it'll just relieve itself to full range of motion. I still have no idea why that comes. Like I mentioned, I get some good results for the sake of improving, but I haven't to date resolved a full frozen shoulder yet, full disclosure. And there might be another AMIT practitioner out there, an NPI practitioner that knows more about this than I do. So if he does, awesome. Give him a call, talk to him about it, find out his success rate, and make sure that you're not, I don't want to say wasting your time, because even if you go from 30 degrees to 120, that's pretty darn good improvement, most people will say. But yeah, give them a call. All right, the 15th, the one that I wanted to cover, is just a collarbone fracture, a clavicle flat fracture. That happens if you have a trauma. All it takes is about 15 pounds to break the clavicle. Hey, and fun fact for you, now we're down a rabbit hole. When I was going through anatomy class, my professor said, hey, it only takes 15 pounds to break a clavicle. So ladies specific, if if someone's trying to grab you from behind, or you're having a tussle with someone who is trying to take advantage of you, or otherwise you need to get away, grab your elbow, bring it up high, and smash it down. You aim for the clavicle and you go hard, because all you need is 15 pounds. You break that clavicle, it is not going to feel good. Your assailant's not going to be happy, and that should give you enough time to get away. So I loved that fun fact that my anatomy professor gave me back in grad school. So I give that to you now. You're welcome. But this is just one of the most common sports fractures. There are a couple of things with this one. If it completely breaks and separates, then they're probably going to have to surgically put the two ends together. But oftentimes this will just break, and the physician will say, just wear a sling for months and it'll heal on its own as long as you don't move it. So like many fractures, I'd say don't come to me if you've got a fracture. I can't help the broken bone, but likely as a result of the fracture, you probably damaged and shut off some pec muscles, some clavicle muscles, likely the deltoid. Any muscle that attaches to the bone, the clavicle bone, will likely have shut off as a result of the fracture. So if you find that after your fracture healed, 2 or 3 months later, but you still have weakness or pain in the shoulder, get in, we'll get those muscles activated. Okay, thank you for sticking along for so long. It's been, 45 minutes or so. I just want to cover that most shoulder problems boil down to the muscles or the nerves not doing their job. If we can get those muscles doing their job, then you should be right as rain. In closing, the idea is we get muscles working, the shoulder feels a lot better. Pain doesn't always mean surgery, but many injuries will recover with the right approach to it. So find out what your body responds to. I hope that this education today has led to you gaining knowledge and gives you some power to make some good decisions for your care in the future should you have a shoulder pain. We'll see you next time. Thanks for sticking around.